and I'll be hosting the webinar. We have an exciting agenda prepared with some excellent speakers who are going to approach today's topic from different angles. We've scheduled about 1.5 hours for the whole event, and during the first half of the session, we'll have presentations from our panel, which consists of Richard Humphries, a senior advisor for the Health Foundation, visiting professor at the University of Worcester and commentator and author. We also have Liz Howarth, who is a programme director at the National Association of Primary Care, and Dr. Justin Varney, who's the Director of Public Health at Birmingham City Council. Following the speaker presentation, we have set aside about 30 minutes for questions and answers. However, before we get going, I'd like to briefly hand over to my colleague Rob, who will explain the etiquette for the webinar. Thank you, Rob.
Thanks, Coffee. Good morning, everyone. So throughout the webinar and during the presentations, please feel free to use the chat to post questions and share your thoughts, and then we'll address those in the Q&A. If you see a question that's in the chat that's really good or similar to the one that you wanted to ask, then please like it, and then that way we can track which ones are the most popular. We really want to encourage a frank and an open discussion. So while we'll be recording the speaker presentations and sharing them after the event, we'll pause the recording when we get to the Q&A to allow for Chatham House rules. To ensure for a smooth experience, I'd like to go over a few technical aspects. So if you encounter any technical issues or have trouble hearing or seeing, please let us know in the chat box, and one of the technical team will try to assist you as quickly as we can. And you'll also see that your microphones have been muted as you join, which is just to aid the speakers by minimizing background noise. However, you can leave your cameras on if you feel comfortable. It's always nice to see people's faces. So without further ado, it's back to you, Coffee, to get us started.
Okay, thank you, Rob. I'm a GP, and I've worked as a clinical lead for Croydon CCG and a training hub chair for Croydon. I'm also currently working as an LMC medical director at Surrey and Sussex LMCs, where I lead on premises and provide both pastoral support and CQ support. I'm also leading the maternity and parental leave workshops, and I'm collaborating with other LMCs across the country on this. And I'm at present working as a healthcare consultant for Mott MacDonald, supporting PCNs with their clinical and estate strategies. So for me, why is integration and collaboration so important? Well, at present, we're seeing such an increasing demand and pressure facing the NHS. We've got a significant challenge ahead of us. As a GP, I'm seeing such a huge growing demand for healthcare services, driven by an ageing population, increasing chronic illnesses, and we've also got advances in medical technology and healthcare. This is all placing immense pressure on healthcare resources and infrastructure. Also, we've got workforce shortages. There's a shortage of healthcare professionals across all various disciplines, and also we're seeing reduction in our non-clinical workforce as well. We've got and then we're seeing this is also having an impact on increased workforce capacity and leading to increased workloads and burnout and challenges, which is affecting the delivery of timely and effective care. And I'm seeing this with my LMC hat on and as a GP, and supporting lots of GPs that are currently facing burnout, and increasing workload is a huge challenge for us all. We're also seeing the financial constraints, and the resources are so finite at present, and that's posing a huge challenge for our commissioners. And I've been on the side where I worked at, in the CCG, and working with my colleagues and the commissioners, the huge impact, the tight financial framework that they're working within, and the budgetary constraints, while also trying to deliver such high quality healthcare. And this is having a huge impact on all our resources and affecting patient care as well. So achieving seamless integration and collaboration across care across the different healthcare providers remains a huge challenge. And so for today's webinar, we're lucky to hear from our panel of speakers to share their wealth of knowledge and experience on the significance of integration and collaboration in healthcare. So our first speaker this morning is Richard Humphries. I'm just now going to hand over to Richard. Thank you, Richard.
Yeah, sorry, I'm not sure if you could hear me there. If I could have my first slide, please. I worked out that this is my 5th decade in various initiatives to achieve integrated care. Next slide, please. So this has been a very long story, and I'm sure there's lots of mistakes I've made that I could share with you. But this is briefly what I want to talk about in the next few minutes, and I'm going to cover this at breakneck speed, but the slides will be there for reference purposes for you to look at in more detail. And I particularly want to make the case why integration is so important, the opportunities we now have with the integrated care systems and the importance of local government being really engaged with that. And I want to signpost you to loads of examples and evidence about all of this. So next slide, please. Yeah, so this is where we are now. It's possible to pick holes with this and complain about it, but the point is this whole new structure of integrated care systems was introduced last year to make it possible to encourage partnerships and collaboration, to sweep away the old structures that were based on notions of competition. It was very fragmented. So the whole point of this new sort of framework of organisational and service responsibilities is to make it easier for us, and particularly at those 3 levels of system, place and neighbourhood. So this is where we are. This is what it is. And I would argue that we're not really going to make this work without the very active engagement of local government. I just want to briefly make the case about why integration is so important. Next slide, please. Why they are must-dos. Next slide, please. And this one slide sums it up for me. It illustrates the explosion in complexity and acuity of people's needs in the last 15, 20 years, maybe longer, and why so many of our services are under so much pressure. And one of the big driving forces, next slide, is multimorbidity. Now, I don't expect you to absorb this slide straight away, but do have a look at it afterwards, because it shows the list of conditions that people have and what percentage of people also have another condition. And when you look at it, it's a bit scary, actually. Because this is now the reality. This is now the meat and drink of modern health and care systems, not just in the UK, I would add. Next slide. And to meet those complex needs, it's not helped by the fact that we've got this fragmentation of services between hospitals, between primary care, community services, and social care. Next point. And we know that the demand for health and care and its costs are rising faster than available resources. So we simply can't afford to waste resources on duplication, on doing things twice, on not getting things right first time, on multiple handoffs. So again, we have to collaborate to make that a much more seamless and efficient experience for people. Next slide, please. And we also know that the world is much more complex, and no organisation on its own can achieve its objectives without the cooperation and participation of its partners. A really good Reith lecture a few years ago by Atul Gawande called The Age of the System, in which he articulates that very well. Next slide, please. So integrated care, which I want to define loosely as coordinating different resources around the needs of individuals, is now absolutely vital. But next point, it's also about improving population health and well-being, because we really have to bear down on some of the underlying demands that are feeding the rise in acuity and complexity and the number of needs that people have. So that we can reduce the need for formal services. This is going to be a key litmus test of the effectiveness of ICSs. Next slide, please. And it is about populations as well as individuals. This has been one of the big shifts in thinking about integration, I think, in recent years. Others will be talking about this in more detail, I expect. But what determines our health? We know that depending on which study you look at, probably less than 20% of our health is determined by formal health care services. So we talk about population health and the 4 pillars of it. We tend traditionally to have focused on an integrated health and care system, but actually looking at those other things, the wider determinants of health, our own behaviours and lifestyles, the places and communities we live in and with. And these are crucial areas for local government activity and responsibility. And this is why I say that ICSs will not work effectively unless local government is really playing its part in addressing some of the underlying causes of poor health and the things it can do to promote general health and well-being. Next slide. The best articulation, I think, of the role of local government is in a very recent report by the King's Fund, which actually is about district councils, but actually the arguments, I think, apply to local government at all levels. And this is based on fieldwork in Lincolnshire, Leicestershire, Norfolk and Waveney, and Suffolk and North East Essex. And you can see there some illustrations of the different ways in which local government not only can support some of the pressures in the NHS, but actually address some of those fundamental causes of ill health in the first place. And what that research did, next slide please, was to identify 4 principles of success. The first one was really about creating effective local partnership structures and making sure your ICS arrangements enable everybody, including the district councils, to be included in that. Secondly, how you align agendas across all levels in the ICS, and what is the golden thread that goes through the whole lot that everybody can identify with. What is that unifying shared purpose? The third point was really about embedding district council or council leadership throughout the system and ensuring that local government leaders are fully engaged and active. And the fourth, and I think absolutely the crucial point, is about investing in relationships. And this is important because the organisational geography of health and local government in England is incredibly complex. Unless you have the great fortune to live in a unitary place where there's one of everything, but particularly in county council areas, it's a nightmare. And you've got many councils who kind of are part of more than one ICS, spend all their day all their time just going to meetings. So the thing that's going to make it work there is not these complicated structures and geographical overlaps. It's the relationships, it's the chemistry between key people, and I can't emphasize that enough. There's loads of examples, next slide please, of places that are really trying to do things differently. Here's some examples from NHS Confederation web pages on integration. These are very much focused on health and social care traditionally. Next slide please. And what I want to do is pull it all together. If you could bring up all the points on these this slide, please. And I don't have time to talk through it. What I've tried to do is just distill 10 fundamental lessons from the evidence and indeed from my own personal experience. And I'm just going to pick out a few things here because I know that we're tight on time. The first one is about focusing on the needs of the population as well as individual care, because we have to bear down on those things that are feeding the amount of need that we have in health and social care. ICSs have got this massive challenge of how on earth Do you do all the short-term stuff, the crisis management, the elective recovery, the numbers of people coming in through the front door, with those longer-term transformative shifts towards prevention and health improvement, tackling the social determinants? That's a huge challenge. This is where I think local government could really help, particularly on the transformative side. One of the mistakes I've made, I mentioned mistakes earlier, I spent far too much time in my career looking up to NHS England or whatever, Department of Health, the latest bit of policy guidance. And I'm not saying we can ignore those, because we can't, but I wish I'd spent far more time looking out to my local communities, my local partners, and looking at many of the solutions and the assets that are there. I hope that ICSs will uphold that principle of subsidiarity, that it won't all collapse into a very top-down kind of management approach, because the best solutions, in my experience, usually are local. Point 6 there, be clear about what you are trying to achieve and realistic about how long it will take. This is the classic Achilles heel of many integration initiatives. People have expected too much to happen too quickly with too little in the way of resource. But I think the biggest emphasis I want to place is about this relationships, this saying that progress happens at the speed of trust. We can have the best governance arrangements in the world, but it's actually people that deliver change. And it is that personal chemistry which you can't sort of mandate from the top. So hence the expression, the soft stuff is the hard stuff. And the very fact that I can say this is my 5th decade of working on different integration initiatives reflects that if this were easy, we would have done it years ago, and it isn't, and it is hard, and we will make mistakes, and we will not be effective all of the time. But I think progress is possible, and I think also we have to remember that we have 75 years of accumulated difference between the NHS and local government in terms of governance, funding, structures, accountability, and so on. So there's some really deeply embedded fault lines there that we have got to try and manage and overcome. That's why it is so hard. But progress is possible. Final slide. Loads of examples and resources that I've put on here. So a lot on the NHS England website. There's a brilliant explainer actually on the King's Fund website about how ICSs are supposed to work, and I would encourage you to use that, particularly with colleagues from outside of the NHS, and do not assume that everybody understands all this stuff about health and care partnerships and integrated care systems, because often they don't. There's a lot of resource there. I've picked out some particular examples, the link to the King's Fund reports and work that the Local Government Association have done on strategic collaborative planning and commissioning, lots of case studies, and a couple of particular studies about particular interventions. So I hope that's really helpful. I'm looking at the clock. I think I'm more or less on time. I said I would do this in 10 minutes. So I hope that hasn't been too much of a gallop, and I really look forward to answering any questions later on. Thank you very much.
Thank you very much, Richard, for your presentation, for sharing your experiences. From all your experiences, what would your top tips be for people who are relatively new to partnerships and collaborations?
So, gosh, I mean, on the last slide, but one, I tried to summarize what I thought were the 10 key points. For me, the biggest single thing would be relationships, and actually just finding time to spend outside of formal meetings, just to get to understand each other's agendas. And in my last sort of full-time big role running a system, that's what we used to do. Local government, the 2 health trusts, we would have a lunchtime meeting with a sandwich every couple of weeks just to chew the cud. That as simple as that. And it's getting that trust, it's getting that relationships, it's understanding. It's also being able to disagree without everything falling apart, because sometimes we do disagree. There are different points of view about things, and it's really, really important that we can manage that difference, but keeping that collaborative show on the road. There you go.
Thank you, Richard. That's really helpful. Thank you. Really excellent presentation. So I'm now going to hand over to Liz Howarth to share her experiences. So thank you very much, Liz. Thank you.
Thank you so much, and good morning to everybody. And it's really interesting actually, because it's like Richard has set this up so perfectly actually for me to now build on some of those key points that Richard was just talking about and take things to maybe more of a kind of program level. Certainly the things about communities, relationship, population health. So the example I'm going to talk through this morning hopefully gives a bit of a sense of an approach and a way of maybe tackling some of those things around population health, relationships, and how you do it in a way that is meaningful to members of staff, and actually you can do it at scale. So what I'm going to sort of talk about is one of the programs that I'm involved in. I'm involved in a number of national programs, but this is one that we call a program, but actually it's more of a social movement. It's really interesting, and really interesting how that is relating to integration and the spread of the work that we're doing. So this is a program of work that I'm involved with the National Association of Primary Care. So in itself, it is sitting very much at the moment primarily across primary care. And we are working in all 42 systems across England. So some of the key messages I just wanted to start the presentation with, and again picks up very much what Richard was saying. Some of this and this programme that we are working on in primary care is really starting where people are at and starting with what people have got, recognising the capability and actually the kind of influence and power of local staff. It's thinking about population health, not management, but improvement. And there is a difference there. And it's making population health improvement very accessible to members of the staff who are working on a day-to-day basis. And I'll talk a bit more about that. It's working with the time that people have got. And it's factoring this kind of work into, even if it's half an hour, 20 minutes that somebody might have in a week, how do you keep that going? How do you build on that? It's also recognising, and particularly around population health improvement and any projects around it, a project can be very small and it can scale. And that's really key, I think, to getting people involved in the first place, because it can all seem so daunting, so huge when we start talking about population health that people don't know where to start. And also it's recognising that in primary care in particular, there are members of staff who are absolute super connectors. They work with different people, different organisations, families, carers, etc. And they are really powerful in knowing how to influence and how to tap into other resources. So if we just move on to the next slide, I'll just say a little bit more about this programme that I'm talking about. And before I do, this is just, again, a kind of diagram to describe perhaps what's happening at the moment in primary care, where there's still quite a lot of sort of siloed working. People have got very sort of defined roles, defined remits, and where we're trying to move to with integrated care, with this programme of work, which is far more of that team, we call it maybe neighbourhood teams, working far more as one team, understanding each other's roles, understanding how to kind of get the best out of each other, how to work in that more sort of what we call, seamless way, coordinated way around the population and around individual people. So that kind of what sits behind what we're trying to do, and a real driver behind this programme. So moving on to the next slide. The programme of work I'm talking about is called the CARE programme, which stands for Connected, Authentic, Resilient and Empowered. And these aren't just words that we decided to put together so it sounded really a snazzy kind of and a memorable sort of title. These are things that are really, really embedded into this programme of work. And we started it just before the pandemic, actually, literally as lockdown hit. And we had this huge conversation about, do we, is it the right time? Do we go ahead with it? How will people respond to it? And actually, I don't think in a bizarre kind of way, it couldn't have been a better time. It's really strange how these things happen. That people in primary care in particular were wanting to think about the amount of change they were having to do. How could they do it so it didn't feel overwhelming? Very, very importantly, one of the key pillars, as you've seen that triangle on the diagram, is about well-being and resilience. And a fundamental element of this programme of work builds on building well-being and resilience as a way of actually supporting people to feel able, ready, willing to do change. And that has been such a strong element of then enabling people to feel that they can do something, they can influence others, they have got a bit of headspace, and support actually to try something, to test something out. So this programme has been built on 3 pillars, one around population health improvement, one around well-being and resilience, and the third is about leadership in primary care. And we started off very much in the beginning working with nursing colleagues, particularly practice nurses who actually hadn't had that much training and support, certainly not sort of leadership training and support. And now it's built out where we're working with all colleagues across primary care and social care, bringing people together around a programme of work. There's sort of 8 modules, but we work with teams and people sort of up to a year to really develop and embed some of the learning, putting things into practice. We also make sure that we talk to the local system and the leaders around that system, again, to understand how can they support, how can they get out of the way sometimes to help this happen and let people do this. How can they support from a governance perspective and link into other things that might be happening? So it's that kind of dual process that we run on this. If we just move on to the next slide. In terms of kind of where we've got to, so we're working with all 42 systems across England. We're actually about over 700 people who are actively involved in the care programme now. We've got over 400 projects in different stages of development, having impact on population health, impact on staff and local communities. And there's a whole variety of projects that are underway, from kind of disease specific to singing groups to help with COPD, to with staff welfare, walking groups, a whole range. And it's really interesting. We're getting more and more evidence and support around us to really bring out the insights and saying, well, so what is the difference that this is making? So again, if we just move on to the next slide. In terms of the benefits, so we work with people for sort of 8 weeks initially on a programme, and then we support people, say, over a year and take it from maybe a very small project to can we scale it? How can we develop it further? To looking at, is there an opportunity to actually change the model, new ways of working? And some of the things along the way, you'll see that, we have great responses in terms of people's job satisfaction. There's a big element of this about staff retention and how people feel. And also it's been amazing to see what people have gone on to do. You'll see that people feel far more able to influence their leadership skills, feel that they have developed. And what's really, really interesting, and I think this is the thing that Richard was saying about relationships, the work we've done, we asked people about, as a result of being on the programme work, how many new people have they connected with? And on average, it's 6 people, which may not sound a lot, But when you think about sort of 700 people, and that's on average, and some people are doing a lot of work to connect much, much broader, much, much widely with other organisations, people, that's when you start to get this kind of social movement. So just moving on to the next slide. This is just an example. I'm not going to go into the detail, but a lot of the work we're doing behind this is the power of activation, whether it's patient activation or staff activation, and how this can have a cumulative effect. From if you activate and you get one person, whether it's a member of staff or a patient, more involved, activated, how over time they can influence, activate other people, which may be still around the existing ways of working. And then it kind of builds that they then start to look at, influencing more people, activating more people, having a broader impact, thinking about new ways of working, changing sort of models of care. And this is the work that we're tracking through the care programme. We've got a lot of evidence around this. But just thought I would just show it very quickly this morning as a way of thinking about how to measure impact on this. So final slide. Again, just some sort of takeaways. I think Richard said quite a lot of this already. One thing I will say is that, no change without kind of frontline change. This is a programme which is starting from the kind of frontline, building outwards, upwards, sidewards. Recognise we all work in these really complex adaptive systems. So, if you can get these actionable insights and get this momentum going, that's how you build it. And I suppose what Richard referred to is almost thinking as a system. What or who or how are you? What's your kind of way of integrating? What are you using? It's not about governance. It's thinking about what are some of the programs or things you've got in place. And my last takeaway is this, I think, is a program that is turning more and more into a social movement, and it's really interesting to see how people involved in it are really taking this forward and influencing others. So I'll stop there, but thank you very much.
Thank you very much, Liz. That was a really interesting presentation to hear about the programme. Can you say why do you think this programme is having such an impact?
I think it is because we are, like I say, working with the time people have got. We're trying to recognise that and make it feel manageable for people. It's not daunting. We're also doing evaluation, kind of real-time evaluation, again, working with members of primary care team, evaluation that feels accessible to them, and it doesn't feel too daunting. And I think it's because we've had this, we talk about, influencing, and we've had a group of almost like first followers who are now influencing others and getting more people coming on board and talking about this. And because we've got so many case studies, again, that feels accessible for people, I think people feel this is something I can do, is manageable within the time I've got and the role that I've got.
That's great. Thank you so much, Liz. And it's really, really helpful to hear about the programme. I'm now going to hand over to Dr. Justin Varney to share his experience now. Thank you, Justin.
Great, thank you. Hi, colleagues. So I'm going to come at this from the kind of reflection of our local ICS system, which is Birmingham Solihull, and I sit on both at the partnership level of the ICS, but also on the ICS board. My reflection, I'll give you a starting bit of kind of context of where we are in Birmingham Solihull, but then talk a little bit more about the kind of skills in navigating that space across a system. So if we move on to the next slide, and then the one after and that. So if we move on to the next one, just to give you a context for those of you who aren't familiar with Birmingham Solihull, so Birmingham's a unitary authority and Solihull's a unitary authority as well. Across the ICS with a population about 1.3 million. The majority of Birmingham are living in very deprived circumstances. We're the first authority in the country to go to a white British minority. But Solihull is a more affluent authority with a much older population as well, though it has growing diversity and deprivation. So it's an interesting system to work in. We also have one of the largest NHS trusts in the country with University Hospitals Birmingham, as well as multiple specialist organisations like National Orthopaedic and Birmingham Women and Children's Hospital. And navigating this partnership of the system has been a really interesting journey over the last year as we've come together, where previously we had 2 clinical commissioning groups working covering the same footprint. We now have one ICS, and originally we had a Birmingham Solihull clinical commissioning group, and West Birmingham was under a different clinical commissioning group with Samwell, and then as part of the Black Country STP. So that just gives you a bit of a context of the framing of this. When we think about the ICS partnership as well, when we're thinking around partnership with voluntary and community sector, for example, we're into the thousands of community organisations in Birmingham. We have over 440 schools in Birmingham alone. So when you think about system partnership engagement, we're really thinking at a very large strategic level, but with a lot of people and a lot of organisations to interconnect with. If we move on to the next slide. And when we think about how we connect with our communities, we're using a language around communities of place, communities of identity, and communities of experience. And one of the challenges we have at an ICS and a system level is how do we have meaningful connection and engagement with these different types of community? Because the reality is that some of us will identify with the geographical place in which we live or work. We may or may not recognise the local authority language of ward boundaries. Many of us will identify with multiple communities of identity, whether we identify, for example, as a cisgender man or as a gay man or as a man connected to an interracial set of communities. All of those are different communities of identity in which to connect, and those also connect with different sets of inequalities and ways of understanding inequalities. And then the third group of communities of experience is our way of describing communities which are linked through shared experience. And that might be shared experience of diseases, for example, people who have lived experience of mental health. It might be experiences like homelessness or experiences of the care system, or it might be experiences related to employment such as sex work. And that's where we kind of think of these communities in different ways. And we think of a system, how do we work? And particularly when we talk about a narrative of being citizen-centred or patient-centred, recognising those two, not necessarily the same population, actually understanding how people live their lives is really key to getting to delivering services that work for citizens. So about this time last year, the chair of the ICS and the chief executive of the ICS, when set the challenge of developing their long-term strategy, came to me and said, we would like you to hold the pen as Director of Public Health in leading the development of the strategy. And we'd like you to do this because you are recognised and acknowledged as someone who works across the system, but also if we write it ourselves, we feel we won't necessarily take on board much of what Richard alluded to about how an ICS needs to work in a system way across the breadth of partners. And the opportunity of the ICS is not to do everything in the corporate blue NHS approach. I should say I spent the first 20 years of my career as an NHS doctor in the NHS system before I moved into national government and local government. So the next slide just gives you a bit of the journey that we went on in terms of developing our approach over the last year. We did a huge amount of engagement and co-design, although that wasn't required by NHS England. We ran public webinars, workshops, it was post-it notes akimbo in terms of developing this. so that we would be confident as a system that we were developing a 10-year strategy that really had buy-in from the system partners and wasn't just following whatever the national team told us to do. And many of you will have been on this journey in parallel with us, and the joys of changing timelines and deadlines to deliver. But I'm pleased to say we managed to launch the strategy in the spring of this year, and a key part of that was also launching a dashboard of indicators. So if we move through the next slide, and I'm sure you'll have access to the slides afterwards, we have a vision statement around wanting everyone to live longer, healthier lives, a commitment to developing culturally safe and culturally intelligent services, to empowering and enabling dignity and choice, and recognising the needs of those who are most vulnerable. We keep moving on to the next slide. And again, I would expect many ICSs will have similar kind of shared objectives around integration. And these are really easy words to write. They are not necessarily easy things to deliver. And one of the great challenges of working at a scale of a population of 1.3 million is that you can have a lot of jewels, but no necklaces. And I use that analogy because Birmingham is a city of 1,000 trades, and still about a third of all jewellery in the UK is made in our city. But it's a really good analogy when you think about how in the ICS we're really good at doing little pilot projects, brilliant stuff dotted around the place, but it doesn't connect that necklace of wiring that turns it into a coherent piece of jewellery. And the real challenge for the ICS in this space is to think about how do we create necklaces, not just lots of gemstones. Because from a citizen perspective, what you see is a random pile of jewels. It doesn't actually work unless you connect the wiring. So, and that again is why we've looked at this in the kind of the visual representation of the circle around the citizen. If we move on to the next slide, the other thing that's important, I think this has been probably the most tricky bit of the development of the dashboard. And the dashboard is publicly available. We publish our indicators on the Birmingham City Observatory for everyone to see. They go up the same time there as they go up for all the GPs, for the NHS partners as well. But the ICS partnership was very, very specific around a strategy is only useful if it has clear indicators and metrics of how we're going to deliver. And we have a set of 10-year metrics like life expectancy and obesity, because anyone who promises you that they can turn around childhood obesity in less than a decade is frankly selling you snake oil. But we've got some that are much more amenable to faster change. And included also, we have metrics which are specific to communities of identity and experience. And this just gives you a flavour of some of these. Moving on to the next slide. We set out also 5 big differences we want to see, and being concrete, and these were tested with citizens and with clinicians in the system around, are they realistic? Can we achieve them over a decade? People really recognise these are not going to turn out quickly. And that actually integration and partnership takes time. There's a huge amount of work needed. And the next slide kind of gives you that sense of some of the kind of system relationships. So if we move on to the next slide, please. And it's probably a bit small on your screen, but there's a lot of people involved, and we've got to think about systems across, up, down, diagonally, multiple dimensions and multiple layers. And that brings me to my final slide, and perhaps the bit that I want to dwell on most with you today. Is doing all of this is looks great, and it's easy to write a beautiful document with nice pictures, but actually the hard work is building the collaboration. And I'm fortunate in I've had a career in which I've worked in the NHS, both clinically and strategically. I've worked in national government and regional government, and then I've come to local government. So I have experience of understanding the power dynamics, the system pressures, and the narratives in multiple different systems. And that's a really useful set of skills, but it's one that's quite unique actually, because we don't have an environment which enables people necessarily to move between contracts, between the public system. It's hard enough moving between primary and secondary care, let alone across into local government, and there are all sorts of challenges and barriers on that. There is a lot of history, and we've got to acknowledge that our history is with us, that we all carry lived experience, and that influences and challenges us around trust and confidence. And particularly when it comes to money, that's often where it gets stuck, is people's trusting of being able to share budgets and actually really have confidence there will be full accountability and transparency. And there are many areas where as an ICS we've been learning around this. We're trying to move as a system to open book accounting across all contracts. Now that's quite a challenging thing. When we have block contracts in the NHS, actually open book accounting isn't something people particularly used in the past. But if we want to have trust and we want to have collaboration, we've got to have authentic conversations about what the real costs of things are. And that's also particularly true when we're working with our voluntary and community sector. We shouldn't have different bars on transparency for different providers. And that's a really important thing to kind of take on board, I think. Authentic metrics and transparent metrics is really important. Holding each other to account with public dashboards on actually how are we making progress is important. The two last points I want to share with you. One is around engagement. It takes time. I think all of us through COVID have recognised that engagement and collaboration with communities is essential to delivering what we need to do in terms of turning the curve on the burden of health in our communities. However, most of us aren't trained to do it. It isn't part of any of the medical training. We're designed to teach to engage with people one-to-one, not in community forums. All of that, there is huge gaps in terms of how we train people to engage with communities. It requires a level of cultural humility and understanding, which requires us as leaders to step into spaces where we can be comfortable being uncomfortable, particularly when we start to have radically honest conversations. And some of the work we've been doing in Birmingham around the inequalities affecting our African and Caribbean communities over the last couple of years, jointly between the Council and the NHS, have been fascinating and frankly quite brutal experiences of radical honesty with communities. But through that, we have built better trust, better relationships. And I think for once there is a joint feeling there could be light at the end of the tunnel when it comes to decades of marginalisation and structural discrimination. But that's brave space. And that requires leaders who are able to and have the emotional capability and also the ability to offload the emotional labour of operating in it. And then the final element is this point about being multilingual. Actually, being able to speak more than one system language is quite an essential skill when it comes to collaboration and integration. Being able to translate when the NHS asks for something, and we had some fascinating experiences of this during COVID, and when the Department of Health or NHS England asked for space for a testing bus. And there's a particular kind of way the NHS estates language works, which is different from the way that local government estate language works. And they were talking about the same thing, but talking slightly different variations of a theme, and therefore both sides were going, the other side doesn't understand me. And being able to step into that space and go, actually, let me listen to both sides and let me play a bit of translator role is a really important skill set to have in a system. And through learning, you can't really just send someone on a 1 hour course and go, here, go learn how to speak local government. But it is a skill set that fundamentally we all need to, I think, develop and work towards if we're going to achieve the ambition of the ICSs to really change citizens and patients' experiences and to realise the ambition of integration and collaboration, which at the heart of it is the only solution to maintaining our public service approach in England. So I'll stop there, Karthiki, and happy to take your kickoff question.
Thank you very much, Justin. That was really, really helpful presentation. And I have a question for you, if that's okay. You mentioned about your whole presentation was about being trilingual. How do you learn to speak other public sector languages? You mentioned you can't do a 1 hour course, but how could we at least start to learn to help facilitate our collaborative conversations?
Sure. So I think there is some national kind of level stuff. So, for example, we've sorted the pension block to people moving between jobs because there's a thing called the pension club. What we haven't sorted is recognition of reciprocal service. And that is probably the biggest block to people moving in their careers between the different public sector organisations. So I think there's some national bit that just needs a bit of banging heads together to solve that one. I think at a much more kind of local level, for me, the key bit has been around partially what Rich and Liz have talked about, that soft engagement, those kind of lunches, breakfasts, coming together, bringing people together. But I also think look at integrated training. Across the public sector, we are all facing financial challenges and restraint, yet we're commissioning in parallel training. And instead of having a conversation which says, actually, how do we join up across the system to have the same training on information governance, on safeguarding, some of the mandatory integration would bring people together, and it's something actually National Civil Service do well, is have that integrated training offer, because then you're suddenly you regularly on training courses with people from different public sector organisations. And that really starts to give you a bit of insight and a bit of connection. It also helps you build a peer network, which is broader than your individual tribe within the system. And one of the challenges we have, particularly in the NHS, is that we're quite professionally tribal. I say that having trained originally as a GP, being married to a GP, and it's quite hard to overcome that professional tribalism and create those networks that connect you with different ways of being and different ways of seeing. So I think there's some national stuff to do on recognition of service. I think locally joining up training, and the third is, as individuals, build your peer networks out beyond perhaps your professional tribe.
Great, that's lots of helpful information there. I just wanted to say thank you so much for all the fantastic presentations. We've definitely learned so much, and I feel like we've got so many skills, and I think sharing your experiences has really given us a lot of valuable tools and to help us start our now conversations on trying to help improve our collaborative working integration on a more local and personal level as well. I see some hands going up, but I think just for just to sort of keep the questions sort of and keeping to Chatham House rules, I think we'll now stop the recording. So thank you very much, everyone.